Good afternoon. About stroke rehabilitation in the home setting. We do know that stroke produces several impairments, including weakness or paralysis of one side of the body, spatial and perceptual deficits, speech and language deficits, as well as behavioral problems. In the recent uh, report, among COVID-19 patients presenting a stroke, the following were the manifestations. And what is interesting to note is that when CT scan was done of the lungs, there also were suggestions of fibrosis. So that aside from the common presentations of stroke, there was an additional problem, and that was the fibrosis, which during therapy could lead to decreased endurance and decrease in the lung function. A Cochrane review showed that prior to discharge, patients who underwent multidisciplinary rehab team instructions actually had a decreased deterioration in activities of daily living. If you do nothing to the patient and the patient goes home and just stays in bed, there will be a rapid loss of muscle strength as much as 5.5% per day. And this could lead to a 40% decline during the first week, as well as selective atrophy of anti-gravity muscles. The implication here is that the patient will have very much difficulty in terms of standing as well as walking. And there will be an additional rapid loss of cardiovascular fitness. But the question that is asked is, how early after stroke can a patient be mobilized? This was a study done way back in 2011, where patients who had very early mobilization, that is within 24 to 48 hours, were compared to those who were given standard care. And it showed that those who were given early mobilization actually were able to walk unassisted for 15 meters earlier compared to those who were given standard care. So it seems that early mobilization has a role in terms of rehabilitation. What we're trying to do here with early mobilization is to look at this. You see that this green graph here. This is the graph for neuroplasticity, and it peaks at around 2 to 3 months. So we want to take advantage of this brain neuroplasticity to be able to improve the patient's function. Of course, the first thing to do would be to manage the modifiable risk factors, which were presented earlier. And during the early stage, if the patient is still unable to sit up or stand, it is very important to do proper bed positioning. So when lying in bed, you need to prop up the affected arm with pillows above the level of the heart to decrease edema, as well as to prevent subluxation of that shoulder. And when turning the patient to the side, see the patient is also propped up with pillows under the arm and under the knees. And what you want to do is not to bring the knees together, because if you do that, you would be predisposing the patient to bed sores. Before doing exercises, you have to observe certain precautions. The patient should be febrile for the past 24 hours. The patient mustn't have any difficulty of breathing or problems with chest pains or chest heaviness. If the patient is doing exercises and develops chest heaviness or difficulty of breathing or dizziness, then you'll have to stop the exercises. So earlier we mentioned that fibrosis might be a problem for our post-stroke patients at the present time. So it's very important to provide deep breathing exercises. When you ask the patient to breathe, the patient inhales through the nose and exhales through the mouth. When the patient inhales, the stomach should go up, and when the patient exhales, the patient brings down the stomach muscles like so. See? So it would be good to have the patient hold the abdomen like so that he feels that when he inhales, the, the hand elevates, and when the patient exhales, the hand goes down. Alternatively, you could use an incentive spirometer. The incentive spirometer is an inhalation exercise. So when the patient inhales, the pulse should go up. And you can adjust the pressure depending on the patient's endurance. So with the patient in bed, it's important that the patient also exercises. So if the patient is not able to elevate the arm, um, the affected arm, you could use the opposite arm to elevate the arm like so. And you also need to move the lower extremities. If the patient is not able to do it by himself, then you can ask the patient's caregiver to help out. It is also very important to do ankle pump exercises. Just do, you see, ankle dorsiflexion and plantar flexion. If the patient is not able to do this on the affected side, then again, we ask the helper to do it for the patient. The first thing we teach the patient is to turn towards the unaffected side. And to be able to do this, see, the knee is flexed like so. The patient holds the arm in a straight. See, the arm is extended, and then the patient turns towards the side like so. When the patient is now able to do that, then we teach the patient how to sit up. So when sitting up, the patient now lies on the affected side and uses the strong arm to lift the patient up like so. This is easier said than done. So you might, a helper might be needed to be able to do this, or at least somebody to put the legs down here, like so. So this is the caregiver now helping the patient to go back to bed. So the patient lifts the lower extremity and gently puts down the head of the patient. So once the patient is able to sit up, then we do the exercises while sitting up. And this is one of the exercises the patient could do. This is actually an exercise for trunk control. While holding on to the arm, the patient twists from left to right. And the patient becomes adept with that, then we can proceed to gradual standing the patient. If we do this if the patient is able to sit up for at least 20 to 30 minutes. So initially, the patient is seated like so. Then the patient scoots so that the patient moves anteriorly, and then with the aid of the helper, now stands up like so. And with the patient standing, the patient can do exercises. Ideally, the patient should be holding on to something so that he doesn't fall. So this is one exercise. This is a partial squats, like so, to develop the core muscles. And if the patient is used to that, then gradually you can ask the patient to walk with the aid of the helper, ideally, or a helper with an assistive device like a cane. But after each exercise, you always ask the patient to cool down. You can ask the patient to just do some stretching or to just lie down and relax for at least 5 to 10 minutes. Studies have also shown that if you give exercises that stimulate not only the motor function, but with cognitive, somatosensory, as well as visual stimulus, is further enhanced. And this further enhances recovery as well. Also, enhanced environment during therapy also help. So in the house, at home, you could, ideally, the patient should be near a window. You should have a clock there so that the patient is oriented as to place and time. And also, it would be nice if you have plants there. And if the patient has a garden at home, then we advise the patient to move around the garden, like so. It has also been shown that some medications seem to help in motor recovery. So this is the study done using cerebrolysine for stroke recovery. So the aim of the study was to investigate the efficacy and safety of cerebrolysine supporting the rehab of motor function. So they were trying to look at function of the upper extremities. And the primary endpoint was the ARAT, or the Action Research Arm Test, after 90 days. And this was the result. Compared to placebo, those who were given cerebrolysine actually had significant increase in their ARAT score, which persisted up to 90 days. It should be emphasized that stroke rehab should be individualized, it should be goal-oriented, it should be progressive, time-bound, as well as interdisciplinary. You have to talk to the patient and set goals together with the patient or the caregivers. Otherwise, you will not succeed. If the patient is able to make use of the hand, then you can do some functional task activities like so. So you could simulate opening the faucet, or opening the door switch, or opening the doors. Also, you could try constraint-induced movement therapy. In this case, the unaffected arm or the strong hand is wrapped or constrained so that the patient is forced to use the affected hand, like so, and try to give activities with the strong hand constraint. And this has been shown to be effective as well. The other technique is what you call as mirror therapy. So the patient either sits up or stands with the mirror on the side. The mirror reflects the good arm. And then we ask the patient to move the good arm to its range of motion. And this seems to stimulate the unaffected arm as well. So when you do this in front of the mirror, the tendency is also to move the affected arm. If the patient develops spasticity, there are actually several things you can do. And aside from the non-pharmacological management, there is a study done by Dr. Martinez where he injected cerebrolysine 10 ml deep IM daily for 30 days. And it showed that he had a significant decrease in spasticity after 1 month. It might be good to do a cognitive assessment as well. So this is the MOCA, or the Montreal Cognitive Assessment Tool. And this tests for attention, executive functions, memory, language, visual skills, conceptual thinking, calculations, as well as orientation. This is easily downloadable in the internet. So these are the tests. So this could stimulate cognitive function as well. If the patient develops communication problems, if the problem is dysarthria or slurring of the speech, ideally you ask the caregiver to help the patient in doing some pronunciation of common words. And also ideally, you have a mirror in front of the patient so that when pronouncing words, the patient is able to look at the movement of the mouth as well as the tongue. Other patients might have problems with speaking, expression, as well as comprehension. And this is from the Philippine Association of Speech Pathologists. They made a communication board. So this contains some activities of daily living as well as common problems that the patient might have. So you can train the patient to actually communicate using the communication board, such as pain, difficulty of breathing, or if the patient is hungry or thirsty, like so. Um, this communication board can be used early during the stroke recovery. However, if you do this frequently, the patient might not speak anymore. So later, during the subacute phase, when the patient points, for example, to the elbow, then you say, ano ang masakit? Then the patient points to the elbow, then later on, sabihin mo nga kung saan ang masakit. Ituro mo kung saan masakit. Tapos, anong area ng katawan yan? And caregiver can say, masakit ang aking kamay o masakit ang aking elbow. So, sabihin mo nga, ano ang masakit? And the patient said, masakit ang elbow. So, that is easier said than done again. But with practice, it can be done. It is also very important to promote positive thinking in patients and to watch out for depression. So, if the patient feels depressed, especially in these times, you could actually use your telephone, do video calls, or use social media to promote socialization as well as positive thinking. Also, you can ask the patient to do some relaxation exercises, like so. But of course, if the patient's problems become worse, you might need to consult the doctor. So watch out for depression. And you also need to take care of the caregiver. So hindi pwedeng puro kabig lang. Dapat nagbibigay din. So we teach the patient to be grateful and to thank the caregiver at all times. Also, we can do some mind-body interventions. You can teach mindfulness to the patients. So be mindful about the way he eats. Be mindful that inactivity can lead to further deterioration in function, so that the patient needs to exercise or move. And if there are other problems, the Philippine General Hospital Department of Rehabilitation Medicine has this program called Itawag. So you can either use your tablet or iPad, you can use the landline or the cell phone, or you can use the computer and talk to us at the department from 2 to 4 p.m. And with that, I'd like to acknowledge some of my slides were taken from or borrowed from these guys. So thank you very much.